Hi, everyone. So I'm Sumintra. I wanted to talk a little bit about my Harvard Macy project, which was a cognitive errors algorithm utilized in a sim center course for medical students. But first, I want to give a brief overview of the history of cognitive errors. I wanted to just say I don't have any disclosures. So the objectives of this talk, just to go over cognitive errors again for everyone who needs a refresher. Talk a little bit about cognitive errors and their influence on patient safety. Review of some specific studies teaching cognitive errors. And then a discussion of my own study and the future steps. So very briefly, cognitive errors kind of came about over the past 20 years as an area of increasing research, a little bit based on this 1999 study, To Err is Human, by the Institute of Medicine, which basically found that 98,000 deaths in theory could be prevented just by reducing medical error. So based on that, a lot of physicians were like, well, we should really try to reduce mortality, morbidity. We can decrease hospital care costs. We can do all these things just by looking at both system problems and also the way that we think. So there's been a lot of studies that came out, both through the emergency medicine side and the internal medicine side mainly, looking at ways to understand cognitive errors and how we can try to prevent making these mistakes in the future. One of the main proponents is a guy you've probably all heard of, Pat Cross-Gary. And his main thought process was that if we really understand how it is that we think and how we make cognitive traps in our thinking, then by default, we'll actually prevent making these mistakes in the future. So basically, I'm using the term cognitive error or cognitive bias, but more broadly thinking they can be considered cognitive dispositions to respond. So in other words, these cognitive dispositions aren't necessarily good or bad. They represent maybe one style of thinking, which is sometimes just briefly interpreted as like a system 1, which is fast and unconscious way of thinking, versus a system 2 thinking, which is more analytical and reflective. So sometimes the system 1 thinking is actually a good thing because it can help you be efficient, you can see more patients, you can make diagnoses rapidly. The problem is that using these kinds of mental shortcuts are much more prone to error. And if you don't have some sort of oversight on the way that you're thinking about patient diagnosis, then you can lose sight of certain key problems and run into trouble later on. Key cognitive errors, I'm going to just talk about a few ones that are kind of near and dear to my heart, but also I feel like represent some of the major issues that people run into, especially in the emergency department. The first one I'd like to talk about is anchoring. Anchoring is a tendency to focus on a specific part of a patient's presentation, often to the exclusion of any other information that you gather later on. An example that was really important to me that we looked at in our own clinical quality review that we do through the emergency department was a patient who came in, seemed like she was in DKA, and all of the providers just focused on her DKA. They're like, we need to treat her DKA, we need to get this insulin going. They signed it out to a next provider when they brought her to the critical care area, like she has DKA, and they lost sight of why she had DKA. So there was a delay in getting the urine. They didn't realize she was in urosepsis. She got a delay in her antibiotics and got a lot sicker before she got better. So that's an example of anchoring, and it kind of bleeds into some of the other types of cognitive errors. They're usually a combination of factors that can cause increased patient morbidity and mortality. The next example that is a favorite of mine is framing effect. This happens a lot in the emergency department. The way that a patient is presented to you by EMS or triage can really affect your outlook about how you think the patient is, if you think the patient's sick or not. We often say, kind of jokingly, that you shouldn't trust anybody, you should trust no one. But I would say you should trust no one and not even yourself sometimes, which means that you should reflect on your own internal prejudices that you might have when you're encountering a patient and the patient was labeled as a malingerer or labeled as a drug addict, because you might miss something important. Maybe that patient has endocarditis and their drug addiction is actually a clue and not just a label. So a good example of this was a patient, this was also one of our clinical review cases. This patient was triaged as drunk. He was put in the Elmhurst yellow gown, which some of you might be familiar with. It's just like a marker that this patient might elope, this patient is intoxicated. In reality, he had just had like a couple glasses of wine, and there's a change of shift. It took a little while for the providers to see him, but then they realized that his slurred speech and his ataxic gait was actually due to a cerebellar stroke and not in fact due to intoxication. But there was a delay in that diagnosis and obviously any kind of care that he might have had. And a little bit, the framing effect can kind of inhibit subconsciously how you're going to approach that patient. My favorite clinical error is premature closure. I feel like this happens all the time. It's actually one of the most studied causes for delays in diagnosis or misdiagnosis. Premature closure is basically the tendency to accept a diagnosis, like an early diagnosis, as the most likely cause, the only real cause, before really getting all of the facts or fully verifying the facts for a patient. The best example that I can think of, and I don't have a specific case for this one, but I think about it all the time, is that you have like a young female, she comes in with left lower quadrant pain, she has maybe some leaks on her urine, and you're like, okay, she has a urine infection. Treat her urine infection, send her home, you know, like maybe you don't think about it or really characterize her history well enough, and it turns out she has ovarian torsion. This is an easy miss to make because it's just so hard to diagnose ovarian torsion, but having it in your mind that it's a hard diagnosis, it's really easy to focus on like urine or something like simple, is important when it comes to not making this kind of error. Okay, so now I'm just going to talk quickly about cognitive errors and what influence they have in patient safety. Most of the studies that were done in the past in internal medicine and emergency medicine were retrospective studies that were just basically characterizing different types of errors and how they affected patient mortality, patient morbidity, and their overall like hospitalization rates or stays. And they characterize both systems errors and cognitive errors. And it's pretty easy to see systems errors and think of ways to fix those. Those seemed like more concrete. But cognitive errors became as well like a very like special area of focus because that's more of a mindset of a physician, and it's a little bit harder to conceptualize and figure out how we're going to change that. Geri was a big proponent of the idea of cognitive forcing strategies. And his thought was that if you understand different types of errors and you then employ specific strategies to combat those errors, that you'll then make fewer errors and increase patient safety. One of the best or like most obvious examples of a cognitive forcing strategy has to do with the error of search satisfying. Search satisfying is basically where you see one problem, you see one lesion with a patient, and you just say, okay, this patient has a rib fracture, or this patient has this, and then you stop looking for any additional other problems that the patient can have. But a patient can have as many problems as they want. So basically, a cognitive forcing strategy that Geri talked about in one of his articles was the idea of doing a secondary survey. This is something that's common in radiology. A lot of radiologists have some sort of systematic way of looking at a film, looking at CTs to minimize that risk of not capturing a second or even a third error. If you look at this x-ray, the first thing that I noticed was that the patient has an AC joint dislocation. And the second thing I noticed was that he has multiple rib fractures. But it took me a really long time, and actually I didn't really get this, but he also has a lot of scapular fractures too. So basically, you can miss something if you're just focusing on one thing. And that can apply to more than just radiology. It's kind of how we approach trauma patients as well. You do your primary survey and you do your secondary survey. But one of the questions I always had was, can you just make more and more forcing strategies for every single problem? Is that even feasible? And is it even possible to teach every single kind of strategy? Like, if all of these issues are a little bit subconscious, can this even really be taught? So next I'm going to talk about a couple of studies that influenced my own pilot study. in terms of their ways of approaching teaching cognitive errors and teaching cognitive forcing strategies to medical students. The first study I'm going to look at is a study by Sherbino out of Canada. And basically, he had 54 medical students. They were enrolled in an emergency medicine clerkship. And he exposed all of them to this cognitive forcing strategy seminar, had a lot of like fancy people who were like well educated on cognitive forcing strategies. And they talked for a while, and they went over some cases. And then right afterwards, they did a 2-hour exam. And the 2-hour exam looked at 2 types of errors: search satisfying and availability bias. Availability bias is a kind of cognitive error where you think the most likely diagnosis is the first diagnosis that comes to your mind. And the results were pretty mediocre. The medical students really only looked about 50% of the time for a second diagnosis in the search satisfying cases, and they were only correctly identified the second diagnosis 30% of the time, 30 to 40% of the time. And the same was true for availability bias. They had a case where they looked at a case where the medical students were supposed to pick out an uncommon correct diagnosis, but they're given a lot of clues to support a much more common other diagnosis or incorrect diagnosis. So they only got that right about 33% of the time. So based on that, Sherbino wasn't completely dissuaded. Oops, wrong way. And he did another study. So he did another study, but as you can tell from the title, he also wasn't impressed. He did more students. He had 154 students, and this time he also included a control group. So about 100 in the intervention group, 50 in the control group. And the intervention group underwent the same sort of CFS seminar. The control group got the seminar as a video, and then they could like look at it when they wanted to during the clerkship, but it wasn't like an actual training module for them. And they looked at the same kinds of studies, and they found that the results were essentially the same. No one did better. The only thing that's important to note about this study is that the way they did it is that they did the seminar, and then they did a delayed test, testing their knowledge on the cognitive errors after the end at the 4 weeks. So there was no like pre-test or no test right after the first seminar. So looking at this, at first I was kind of discouraged, but then I thought maybe just the modality that was used in this kind of study was wrong. Like maybe students don't learn as well from a seminar in terms of how they would act or how they would think about cognitive errors. Or maybe the delayed test was too delayed and they had too much just natural loss of any kind of knowledge that they gained initially, so that it ended up washing out any real effect. So I tried to think, are there better ways to teach cognitive errors? And I thought that maybe simulation would be a better way, just because not only is it interactive, it kind of simulates the environment of the emergency department, which is higher stress and forces you in some ways to make rapid decisions and then possibly predispose you to cognitive errors. So maybe this environment was a better way of actually seeing if medical students would respond and actually be able to counter cognitive error bias. So I thought about creating a cognitive errors algorithm. This was based on thinking about Kroskeri's ideas of using cognitive forcing strategies. But I wanted to make it broader and more applicable to just how you would diagnose an undifferentiated patient. I thought about the ways when I was first learning emergency medicine, how did I think about a patient? How did I think about avoiding pitfalls? So you always start with a differential. Either you can start a differential from the chief complaint or you start a differential for after talking to the patient, but you have some idea of a few things that you're worried about. And then I think it's important to think about what is most likely. Even if it's like GERD or like muscle pain, like what's the most likely thing for this patient? And then what is the worst case scenario? That's something that we always learn in emergency medicine, look out for, but it's actually a really good strategy because it helps broaden your differential. It helps you think about the things that are like weird or really scary that you may not have considered if you just look at somebody and you think, well, they look well. And then this is the harder part, is that you need some sort of background in cognitive errors. You need some sort of introduction to the errors to even know what to look out for. But if you have some background in potential biases, and even just a couple of them, premature closure, anchoring, then you can probably think a little bit, future-minded. Am I going down a route of anchoring this patient into one category? Am I thinking that, after I get this next couple of tests, that it's just a urine infection? Do I need to go more? Do I need to look at something else? Do I need to change my plan a little bit? And you can adapt that way. And then ultimately, you create a plan that fits, or at least in some way conceptually addresses the worst case scenario and the key problems that you're looking out for. So after making this basic algorithm, I then designed my study for my sim course. So the course was pretty small. It's only 10 students at a time. I then used an online randomizing tool so that they'd be into 2 equal groups, a control group and an intervention group. And the intervention group had a brief 15-minute session talking about cognitive errors and introducing the algorithm and how I'd like them to use it during the sim. The key point being that they could use the algorithm, that they had it in their hands or had access to it or were thinking about it as they were undergoing the simulation. The control group underwent the sim cases beforehand and then had an introduction to cognitive errors afterwards, mainly because I just wanted to introduce them to it if they'd never thought about it. But actually, a lot of medical students here now get it in their curriculum, so they already had a little heads up. Okay, so the results were promising, but it's still a very small study, so it's hard to make any big proclamations. I did find that when I did the sim cases, I had a checklist of all the actions that every medical student is supposed to complete, and the intervention group was better at just like working together and completing all the actions. I felt like they were more reflective in the sim about like going through the things that they needed to do. They didn't know ahead of time what checklist actions they had to complete, but they did better at that. The intervention group also was able to correctly diagnose all of the cases. I had 4 cases total. Only one was a really outlandish case. It was a venous sinus thrombosis, which I wasn't expecting a lot of them to get. But because they had some sort of team effort, and I think were a little bit more reflective, the intervention group got it, and the control group didn't get it. I also did just a pre-test knowledge assessment and a post-test knowledge assessment, but it wasn't specifically looking at their understanding of cognitive errors. It was only looking at their understanding of floor emergencies, emergency medical care. And I didn't see a change in the average score from that, which is understandable. I wasn't really expecting to see a huge change between the 2 groups, but I was curious to see if just maybe being primed for cognitive errors understanding and thinking about it would make them more thoughtful in their test taking. But it was a really small group, so I wasn't expecting a huge change. I did survey results as well, and I found that almost all of the students were really excited about cognitive errors and wanted to learn more about it. Almost all of the students planned on incorporating cognitive errors and some sort of cognitive errors reduction technique into their clinical practice when they go on into their careers as internists or emergency physicians. And all of the students in the intervention group really liked the cognitive errors algorithm and thought that it was a helpful strategy for clinical diagnosis. Okay. So in terms of the future, I think based on some of the retrospective reviews and composite studies that I've looked at recently coming out about cognitive errors, that sim seems to be a little bit more helpful than lecture format in terms of seeing if trainees are understanding cognitive errors and how to limit cognitive errors in their clinical practice. So it might be a better model going forward. There's also this idea of guided reflection interventions, and it's I kind of feel like it's a little bit of a hokey title, guided reflection interventions, what does that actually mean? But basically, there's been several studies that have come out looking at a specific type of reflected thought process, that could be just saying, I am now going to consider a differential for this patient, or, am I considering any test results that refute this diagnosis that I think is the most likely diagnosis. So just some sort of strategy up front for handling cases And they have found in various studies that medical students in OSCEs tend to do better with this mode of interpreting and diagnosing patients compared with just nothing at all, like compared with just doing whatever you would normally do. So I felt like that kind of dovetails a little bit with my idea of an algorithm. It's like a similar kind of having a strategy up front can maybe help you in terms of not making mistakes or just kind of subconscious mistakes. So in the future, it would be great to just study this with more medical students, perhaps in a similar kind of EM clerkship model where you just keep going every block with students and do a sim where they are introduced to the cognitive errors algorithm or some sort of cognitive errors mode of reflection versus just going through the sims and seeing how they perform. And then the other thought would be to introduce it to interns or introduce it to people on shift and see how well they like it and how well they think it helps them in terms of minimizing mistakes. And you could even do follow-ups on those patients and see if they have a decrease in 72-hour returns or a decrease in mortality. The only thing I would say as a caveat to this algorithm is that I believe it's far more applicable to medical students or interns. It's much more of like a early provider sort of way of thinking about how to handle patients. And I think as people get more senior, they're more likely to find what fits best for them. And the whole idea of how to reach more senior attendings in terms of helping them subvert like any kind of subconscious biases or traps that they might fall into, I think is a whole other kind of area of education which I can't really imagine getting into. I feel like you have to somehow like just you have to like somehow be willing to change yourself and just be more kind of like vigilant at all times. And I don't know, once you become that senior, I'm not sure exactly there's a one-fits-all model at that point. But I think in terms of cognitive errors, there's a lot of hope that it can be taught and it's not all just something subconscious and unstudyable, which I think some people have felt in the past. Okay, so these are my sources. I'd like to thank the IME for their support with the Harvard Macy program and the Harvard Macy Scholarship. If anyone has any questions, I'd be happy to take them now.
Could you just expand for a moment on the algorithm itself that you provided? Was it a form that you gave them, like a cheat sheet? Was there something
it was a physical paper. Yeah, I mean, we discussed it up front as an idea, along with the cognitive errors, but then it was an actual paper that they had as we were going through the sim. And I think in theory, this could be something that people would have on their phones or like have access to if they wanted to. And again, this is, I think, again, more applicable to people who are just starting out in their training as a way of like just checking their own mentality, their own mindset as they're going through seeing a patient for the first time or for several times.
It was a great presentation. So I'm curious whether you noticed or looked at, or other people have looked at the idea of using algorithms like this as an internal check on myself, as opposed to setting it up so that someone else in the process of the team approach in sim, let's say, or for the student or intern or resident, you know, like formally in the process of presenting the patient, the faculty are all told, you need to run every presentation through it. It could take 5 seconds and say, which of these cognitive errors have you possibly committed? So I'm wondering whether one way to apply it that's different and may have different outcomes is, instead of relying on each of us to battle our unconscious biases all the time, making it a formal part of what is explicitly a function of the team, like, even in the simulation space, like one person's job, like it's one person's job to do the oxygen, whatever, one person's job to say, okay, let's run through cognitive errors, or has anybody looked at it like that in terms of where?
I actually haven't seen studies about that specifically, like having like a point person, but I was thinking about something like what you were saying in terms of how, as a resident, that whole like apprentice master relationship that we have, how it's like almost a natural extension that the attending is kind of like talking to you, like, what have you missed, what have you considered? And there are certain attendings who just do that. And those were the techniques that I often, like in training, emulated. Like it might have been like a specific thing that he or she was focused on, like how do you think about chest pain, or how do you think about back pain? But that kind of set the idea of we should always be having some sort of internal check. It might become like so, tedious that you wouldn't want to do it on a very, very easy case, or like when you're working in fast track and you're just seeing like all these fairly obvious things, like that person has a laceration. There is no differential. But when you're having somebody that you're either confused about, or somebody that I also think that you're predisposed to some sort of bias about, and for me that's personally wanting to take a mental check, especially on any patient who has like a psychiatric illness, any patient who is an alcoholic, or like certain things that you want to say. Your tendency is like, well, I can't really figure out why they're having this pain, and they can't tell me anything, so it's probably not anything. Like just check yourself, because that's usually not true. So I think that idea is good, and I don't know. I think in a SIN situation, having a point person actually might be helpful. Like that's a great model to try out. Bedside teaching, I think, is also a great idea. The only question I wonder is how would we then try to capture some result? Would it just be, capturing one, how do the residents or medical students respond to this? And then two, like SIM, it's easy, you can see how they perform. Bedside teaching, I'm not sure how far you're going to look to see a result. Right. But I think it's a really good idea.
Great.
I usually tell my patients that I'm paid to worry, and I'm just wondering, in the end, are running the algorithm, does it kind of come down to really asking yourself, what have I missed?
Yeah. Yeah, I think it's like a fleshing out of what have I missed, and sometimes I think, or for many people, probably what have I missed, or when you're more senior, what have I missed is great. It's all you need. I like to break it down even for myself still at this point, because I'm like a fourth-year resident. But especially for people who are just starting their careers, I feel like they're still working on what a differential even is, for like in terms of expanding it all the way out to what it could be and what the most dangerous ones really are. So I think actually having like at least two sides of it, or like multiple angles of looking at it, kind of helps. But yeah, you're right. It's just having that own check of not wanting to miss anything at the end. Yeah.
Great.
Thank you.
So thank you for that introduction, and thank you all for being here. And I'm really grateful to the IME for providing me the opportunity to go to the Harvard Macy program while I was a fellow. And I'll be talking a little bit about the project that I had while I was at Harvard Macy, which is incorporating the Entrustable professional activities into a curriculum for our geriatrics fellows. I don't have any conflicts of interest or disclosures, though I do have to admit that my 3-month-old was awake all night last night, so I apologize if I'm a little loopy during the talk. So some of my objectives for today are to describe the hospital at home and the Mount Sinai Mobile Acute Care team, to define curricular milestones and entrustable professional activities, and then to finally discuss a sample curriculum for geriatric fellows that links specifically to one of the geriatric EPAs and provides an opportunity for structured assessment of our fellows. This is a roadmap of what we'll be talking about today. And then I'll start with a little history of hospital at home. So older adults are frequently hospitalized. This is a graph that shows hospitalization rates by age tracked over time. And you can see that those 65 years and older are consistently hospitalized much more frequently than those that are younger. They account for over 1/3 of all hospitalizations, almost half of all healthcare dollars, and are often admitted for much longer periods of time. We geriatricians know that there are significant hazards associated with hospitalization for older adults, including functional decline, malnutrition, delirium, adverse drug reactions, and nosocomial infections. So this really begs the question, is it possible to care for our older adults without the hazards of hospitalization? And one proposed model was, would it be possible to care for these patients in the comfort of their own home? And so in the early 1990s, a group led by Bruce Leff at Johns Hopkins developed the hospital-at-home model. They admitted patients with 4 key diagnoses: pneumonia, heart failure, COPD, and cellulitis. They would evaluate patients in the emergency room, bring them home, and actually, with the appropriate equipment, medications. Often a nurse would actually stay with the patient for the first 8 to 24 hours and then transition to daily visits. And a physician would see the patient daily as well and be available by phone in case of emergency. And then at time of discharge, the nurse would provide instructions and then transition the patient back to their primary care provider. What they found is that patients who were offered this level of care accepted it more than half the time. The care was feasible and efficacious. It was associated with shorter lengths of stay for the patients, significantly reduced healthcare costs. And really exciting for us geriatricians is that it showed improved patient and caregiver satisfaction, reduced caregiver stress, and interestingly improved function as opposed to the functional decline that we often see with a hospitalization for older adults. So what are we doing here at Mount Sinai? So they found that hospital at home was a feasible and efficacious model. And so Mount Sinai received a grant from the Center for Medicare and Medicaid Innovation Award to do a 3-year project to determine a financial payment model for Medicare fee-for-service patients. So in addition to implementing the model for patients and continuing to monitor cost, satisfaction, and outcomes, again, the main thrust of this grant was to determine a first-generation payment model to disseminate to other systems. This is a sample of our eligibility criteria. So patients have to live here in Manhattan in the community, so not at a nursing home. They have to be over the age of 18 and have one of our contracted insurances. And we've actually expanded the number of diagnoses that we'll admit to the program. So in addition to the original 4, we'll also accept patients with DVT-PE, UTI, urosepsis, diabetes, and dehydration, which is often kind of a catch-all for a lot of different types of illnesses. We have a fabulous interdisciplinary team that helps us care for our patients. Physician, 3 now wonderful nurse practitioners, a group of nurses, social workers, physical therapists, our administrative assistants, and home health aides, all centered around the care of our patients and assisting the families and caregivers. And what's been really fantastic about working at this program is that it's really grown over time to meet the needs of our patients and our health system. So in addition to the original hospital at home model, which is kind of a short 3 to 5 day acute inpatient level care, we've also expanded to provide observation at home, palliative care at home, transitioning patients to hospice if needed, care for hospital averse patients, so patients who decline hospitalization and want to stay at home. And then finally, one of our more popular programs is subacute rehab, so post-acute rehab in the home in lieu of a nursing facility. And so with this novel program, felt like it was a really wonderful opportunity for our geriatrics fellows to spend time with the program to learn from the various types of care and to be a part of the interdisciplinary team. So I'm going to talk a little bit about a curriculum that we designed to supplement the time that the geriatrics fellows spent on this rotation. So one of the things that we spent a lot of time talking about at the Harvard Macy was the Kern's 6-step approach to curriculum development, starting with problem identification, followed by targeted needs assessment of your learners, setting kind of more global goals and then very specific measurable objectives for your curriculum, developing your educational strategies, which includes both your content as well as the instructional methods, implementing your curriculum, and then finally having opportunity for evaluation and feedback. So not only assessment of your learners, but also time to evaluate the program that you've implemented. And then it's an iterative process, so you kind of continue to refine your curriculum as time goes on. So we started with a needs assessment. So before we developed this curriculum, 11 of our geriatrics fellows had actually rotated with the MACT team. And so we sent out a survey to ask them about their experience. 6 of the 11 responded, and this was a sample of some of their responses. So when asked how many patients they evaluated, the majority of folks said it was less than 5, unfortunately, and that their role was predominantly shadowing. And I think this was a really disappointing response. So when asked if the MACT rotation, where they spent a month, added to their understanding of how to care for geriatric patients and geriatric syndromes, the majority of the fellows said no, it did not. We asked them what they thought their optimal role would be, and uniformly they said that they really wanted to take on more responsibility. They wanted to act as a mini attending, evaluating patients in the emergency department, to really take on that interpreter manager role and actually have much more of a well-defined position within the team. So I'm going to take a pause and talk a little bit about curricular milestones and the Entrustable professional activities, because when crafting our objectives and goals for this curriculum, we really wanted to link them explicitly to the geriatric milestones and EPA. So just as a little bit of a background, back in the 90s, there was a shift in thinking about how do we develop residency curriculum and shifting from really process to outcome measures. And so the ACGME Outcome Project developed 6 core competencies that they wanted all residency education to kind of think about. And those 6 main domains were patient care, medical knowledge, practice-based learning, communication skills, professionalism, and system-based practice. The American Board of Medical Specialties wanted to move and to adapt these competency definitions to specific individual specialties, so having further defined within each specialty what those competencies would be. In 2008, there was the development of curricular milestones. So this is a progression of observable behaviors that can be used to give specific feedback and evaluation to our trainees. And in 2012, the AGS, or the American Geriatric Society, developed geriatric-specific curricular milestones. And so this is work led by our wonderful Dr. Leipzig. So and the Entrustable professional activities are core work that constitutes a discipline-specific expertise. And again, these are observable, measurable tasks and responsibilities that a trainee is expected to be able to do independently by the end of their training. And so in 2014, Dr. Leipzig and the rest of the group really developed what they thought would be the core work of a geriatrician. And again, and all of these EPAs are linked explicitly to different curricular milestones. And so these are the first 6, there are 12 total, about what is expected for a geriatrician to be able to do by the end of their training. Number 1, provide patient-centered care that optimizes function and well-being, prioritizing and managing the care of older adults by integrating the patient's values and goals, assisting patients and families in clarifying what those goals would be, preventing, diagnosing, and managing geriatric syndromes, providing comprehensive medication review, providing palliative and end-of-life care, coordinating healthcare and healthcare transitions, providing geriatrics consultation and co-management, facilitating a family meeting, working with an interdisciplinary team, teaching the principles of geriatrics care to others, and finally collaborating and working on quality improvement and system-based initiatives. And so thinking about how the MACT rotation fit into the larger goals, we thought we could actually pick any number of these EPAs and kind of work with that into our curriculum, but decided really to focus on number 7, which is coordinating healthcare and healthcare transitions, because there are so many transitions that happen over the course of an admission to our program that we thought that this would be a really wonderful time to evaluate and target our education around this for our geriatrics fellows. Again, each of the EPAs links back to a number of the curricular milestones. And so these are the different milestones that link then to this EPA about coordinating healthcare and healthcare transitions. So part of it is seeking and incorporating input from the patient's care team, identifying the appropriate care setting for a patient, developing prioritized care plans, when transferring care, providing a comprehensive assessment for the next provider, and clearly communicating that, and then overseeing these transitions across multiple settings. And so again, keeping that in mind, we developed our objectives and goals for this specific rotation. So some of our goals and objectives were to have the fellows be able to describe what hospital at home is and what some of the evidence supporting this model, to again be able to diagnose and manage common geriatric syndromes, to identify and prevent hazards of hospitalization, and finally, really focusing on that number 7 IPA or EPA is coordinating healthcare and healthcare transitions for older adults. And so what are the strategies that we employed? So the rotation is 4 weeks. Our fellows, this is kind of a sample schedule. So our fellows are only actually with us for about 2.5 days because they have their own clinic, they have didactics, and they go to a co-management clinic for renal transplant. So that kind of proved a little bit of a challenge for how we were going to uniformly implement one kind of curriculum for the fellows. So what we decided to do is to give them an introductory PowerPoint. This PowerPoint kind of reviewed the history and provided the evidence for hospital at home. It explicitly describes what an EPA is and lists all of the geriatric EPAs so that they know where this rotation, how this rotation fits within the larger curriculum for the fellowship. It defines the role of the geriatric fellow on the MACT team, and then it introduces an assessment tool that is linked to that EPA about care transitions. Then the fellow integrates into the clinical team. So again, the fellow is given a clear role about what their responsibilities are, and the rest of the team knows what those responsibilities are as well. And there are multiple opportunities for the fellow to independently evaluate patients and construct a care plan. And finally, there's an assessment tool, which I'll spend a little bit more time talking about. This tool is, again, linked explicitly to that EPA. And we used a rubric to be able to provide structured feedback for our fellows around the different components of those care transitions. Again, this is how we defined the role of the fellow. This information is given to the fellow at the beginning of the rotation, and then again shared with the rest of the members of the team. So for our assessment tool, we decided to develop a rubric with the help of Helen Fernandez, who is my Harvard Macy mentor and an expert in clinician educator, and then Linda DeSherry, who's the clinical director for the program. And then, so the rubric, and I'll walk you through the rubric, kind of defines each component of what a successful care transition would be, and then defines what an unsatisfactory performance would be and a superior performance, and then it asks the evaluator to kind of rank where the fellow would be within that. The providers were oriented to the rubric, so had an opportunity to give feedback about what they thought the components were, and then have practice using it with sample cases. So these are the different components of the assessment tool. So history and physical, functional status, home safety evaluation, did the fellow communicate with the care team, was it a medically appropriate treatment plan, and then did they do a comprehensive home care plan for the patient? And then finally, did they do a thorough medication reconciliation? So in terms of next steps, so we have a lot of things that we still need to do in terms of this program. So one, want to know what the completion rate is for the use of this assessment tool. How often is it being used with fellows? I think in my mind, ideally it would be used multiple times over the course of the rotation so a fellow could show signs of growth. But we need to figure that out. Want to do a learner evaluation again, so similar to what we did of the fellows at the beginning, having a sense of how many patients they've evaluated, what kind of continuity they had, and what was their role. Have them do a self-evaluation, and then also give us feedback on what they thought about the rubric. And then finally asking the attendings, how did they see the use of this rubric? Was it easy to implement and use with the fellows or not? And how was it incorporated into their workflow with the rest of their responsibilities? I think some of the strengths of this curriculum are that it creates clear expectations for what the fellow's role is, and it provides opportunity for structured feedback, which we often don't have over the course of our fellowship. Some of the big challenges is that the rotation is 4 weeks. That can be 4 consecutive weeks, or it can actually be 2 weeks here, 2 weeks kind of 6 months down the line. And it's only 2.5 days of each week. So it's kind of a piecemeal how we get our fellows. The attendings also rotate every 1 to 2 weeks, so there's maybe not continuity with an attending who could have observed the fellows' progress over time. And one of the things that's so wonderful about MACT, but one of the challenges in defining the fellow's role, is that the program itself is constantly evolving and changing. And so how to think about how the fellow's role evolves and changes with it can also be really hard. So with that, I just wanted to thank my mentors and the wonderful MAC team. I'm so grateful to have gone to Harvard Macy, and I'm so grateful to the IME for providing me with that opportunity. So I'm happy to take any questions that you may have. Yeah.
I was just wondering, because I'm working on like a curriculum development
Yeah.
myself. How did you go about like faculty development for the rubric? Did they require, like, how did you actually go about? Do you have certain champions of it, or is it really anyone that's rotating in the MAC program that can evaluate the fellows?
Yes. So I would say that I'm probably the faculty champion at this point. And all of the faculty that rotate through the program, we have monthly kind of meetings for MACT, and so I introduced the curriculum to them at one of these monthly meetings and kind of introduced the rubric to them at that point in time. And then in theory, every faculty member who rotates through should be able to administer this. But I think that that's a huge challenge, and I have to admit that a huge chunk of the time after we rolled out the rubric, I was on maternity leave, so I was gone. And so it's hard to know what happened when I was not there. But again, the hope was in piloting it and working closely with the faculty up front when we developed the rubric was that they would feel more investment in it and then be able to implement itself. But it's hard to, I think there's definitely been a lag while I was away. Yeah.
So the rubric are you doing paper format or online?
Yeah, so it is online, but it's also the idea that they could print it out and kind of walk through with it.
Trying to get captured both ways.
Yeah. Yeah. Whatever's easiest. Yeah.
So it's, to what extent do the fellows see patients linked to any attending? Are the fellows really seeing patients on their own? In other words, how much contact is there between?
Yes. So the attending is kind of overseeing the clinical. There's one attending on service at a time, and the fellows kind of rotate with that attending. So they would have to the fellow would be reporting back to that attending any patient that they're evaluating and seeing. So it's one attending per week. Right. That is kind of overseeing that care.
They're not in a situation where they're going to see a patient together and it's being directly observed.
They could be, yes. Yeah. So, and oftentimes I think that's how it starts is the fellow will go with the attending kind of initially to see how the attending approaches the patient, because it's a little different from a typical inpatient. There are a lot of other questions that we often ask. And so we'll kind of start with shadowing, and then over time, the fellow will probably take on more responsibility and kind of take over the interview, and then maybe doing it independently without the attending there.
Yeah, I mean, for the third year medical students, there's something called Interact, which is not structured as nicely as this in terms of how explicitly expectations are set, but expectations are very explicitly set, and there's a lot of sort of opportunity for formal structured feedback. But the key to what makes the Interact rotation work is that the students assigned to one attending. So even though they're with me, let's say for 2 weeks or 4 weeks at a time, and then they're gone for a couple of months on rotation, when they come back, it's always the continuity piece of it. I wonder whether there's an application of that here, because it would make the rubric more sustainable over the course of time and more meaningful, because it's one person watching you as a fellow kind of evolve over the course of the year.
That would be really interesting.
Great project.
Yeah.
Have you gotten any interim feedback from the fellows? Because we started with sort of some dissatisfaction data from them as far as satisfaction with the rotation.
Yes.
Or experience.
I did kind of right before, after we had kind of implemented the PowerPoint and kind of introducing their role, but before we started the rubric, and they're absolutely seeing more patients. I think that's also, I have to admit, partly because the MACT program itself is admitting and seeing more patients. But there was kind of a mix. Some fellows felt like they were seeing more patients and acting more independently, and some were still kind of taking on that shadowing role. And I think part of that is the challenge of who is the attending and what their comfort level is with the fellow, and how that evolves over time. So, but it seems like it's being people like the rotation a lot. It's just kind of what their role is changing over time. Yeah.
Thank you very
Thanks.
much.